So joining our panel of experts, I'd like to introduce Dr. Victoria Wong. She's an assistant professor at Oregon Health Sciences University, and she's also a member of the Comprehensive Epilepsy Center. As well as that, she's a member of the Epilepsy Northwest Professional Advisory Board, as well as Dr. Mortika is, Dr. Wray is, and Jan Spencer is. So thank you very much.
So we're going to bring back a few of the prior speakers here. Dr. Wong hasn't spoken, but we heard a little bit about her now. Jan's coming back to join us. Dr. Ray's coming back. And one of our speakers from the afternoon is going to be joining us as well, who has some really great expertise here. Kriz is going to help out with the panel as well. You'll be hearing from Dan later on. He's going to be talking about some really important issues having to do with mood and epilepsy, but I think that's an important topic, and so I think it's good to have him on this panel. So we had a number of questions submitted beforehand, and we're going to try to get through those as much as possible, and I think that we'll also open it up to questions in the audience here because that seems to have gone really well, and we have a pretty diverse group of people here: adult epileptologist, pediatric epileptologist, social worker, and someone who has expertise in mood issues. So what I think I'd like to do, because I want to make sure that we get through some of the questions that people took the time to submit, is read a question, and maybe we can alternate it with people from the audience a little bit here and get through some of the questions that I think will have some broad appeal to the folks here. So one of the questions that we received is from a parent who has a teenage son with epilepsy that is not well controlled. He has many symptoms of anxiety, and they're wondering if anxiety is something that is commonly seen in patients with epilepsy. Dan, I'll let you take the first try.
I guess I look like a psychologist. Yeah. Jan, if you have any input on this, I'd be welcome your input also. Great question, and I will be speaking a lot more about this in the afternoon, and I value its importance. And yes, it is more common in children with and adults with epilepsy. I'll get to some specific statistics in my presentation, but the take-home message is that yes, it is more prevalent. And I also want to take into account that anxiety can also be adaptive. It's not, I don't view it as becoming a problem until it interferes with somebody's life and an aspect of their life. I know I have some anxiety right now about speaking, and so it is a normal experience, but I also think it can become abnormal really quickly, and there's various aspects of a child and a family with epilepsy that can complicate that and allow that anxiety to become problematic for that family.
I think that also segues into a related question, which is, isn't it normal to be depressed or anxious if I have epilepsy? How are these issues related, and are they more likely in patients who have epilepsy? And as Dan said, the answer is yes, not just for anxiety, but for a large number of mood-related issues. Depression and anxiety tend to be the biggest ones, but there are others as well. And to some extent, yes, it's normal to have that reaction, like Dan said, and historically that's been a thought. Years and years ago, people would say, well, sure, someone has epilepsy. I mean, of course they're depressed, or of course they're anxious, and that's true to some extent, but we've learned a lot more about that over the years, and now we understand that in addition to that part of it, there's clearly an aspect, and some patients with epilepsy who have what we would call comorbid mood problems, really associated but very clearly defined mood issues like depression and anxiety. And it's very common. Probably 20 to 30% of the patients that we see have those issues in particular. And it's important to talk about it, to recognize it, and also to treat it, not just because it's a good thing, and we know that it improves quality of life. There's also perhaps some indication, although we don't really know with certainty, that it might even help seizures. So it's something we're learning more and more about, but very, very important areas, because along with just having seizures, quality of life is a big issue, as we've seen already. So important things to discuss. Do we want to maybe take a question from the audience, and then we can kind of go back and forth, get people involved? Anyone has any questions? We'll bring a microphone up there for you.
Who can get there first? Well, like I mentioned before, our son is 6 years old, and he's had epilepsy, we feel, since birth, or epilepsy, or seizures at least, since birth. And I've found, he's, my wife's more of the introvert, I'm more of the extrovert, and I feel he's kind of more of the extrovert. And lately he's been talking about and telling people I have epilepsy. And, you kind of answered the question, is it proven anywhere that, like, people, the individual person themselves, being more open with their epilepsy, tend to be less, have less issues with their epilepsy, or is it, is there any scientific proven facts on that?
I don't think there's any studies on that per se, but I think you have to find whatever works for an individual person, and I have come across a lot of kids where that particular technique has really helped out that person. And so if they're comfortable with it, that means that they're becoming more comfortable with their epilepsy and the world around them. And so I would embrace that. But however, somebody in this room, that same approach may not work for them. And so I think really weighing someone's temperament and personality characteristics when kind of approaching these types of situations is really important.
Great question. Sure.
I had an experience when I was about 12 years old that really changed my attitude about epilepsy specifically, but people with disabilities across the board. And at 12 years old, I had a paper route and went up, was collecting, and I went to this one house, and the lady came to the door, and she, when she found out what I was doing, she went and she got her purse and came back, and she opened her purse, and then she looked up and stared into space and had some peculiar actions that she did when she was having seizures. And being 12 and never having any experience with that, I thought that was pretty strange. And she came out of it, and she acted like, okay, did I just do something strange? And I said, yeah, lady, you really did. And she says, okay, this is what happened. She says, I'm an epileptic, and I just had what's called a petit mal seizure. And she explained to me, and it was such an enlightening thing. Her attitude was just phenomenal. And even at 12 years old, I picked up on that and knew that she had a quality of life that has affected me to this day. So I want to encourage parents, family members, people who have disabilities themselves, that you can make a difference in the people's lives around you by being confident in yourself and confident in what's going on, and explaining to people how that affects you and that they don't have to worry about it. And granted, not everybody is going to be affected the way I was, but even if you only touch a few, that's going to help others with disabilities.
Great points. Let me go to one of the other questions that we had submitted. This came up a little bit earlier. Jan, I'd like to direct this one at you. Tell us a little bit about what you discuss with patients in there's a lot, we encounter a lot of questions about support animals for patients with epilepsy and with other issues as well. Tell us a little bit about what you discuss with them when that comes up.
Yeah, this comes up quite a bit. Companion animals. Okay. Companion animals versus seizure response dogs, seizure detective dog or detection dog. And overall, I think anyone would benefit from having a companion dog. Especially with seizures, we know that we've talked about the buddy system, and so having an animal would be nice because typically animals that we're talking about, people are generally interested in dogs, although you made me aware that there might be other animals like iguanas, which wouldn't come on my list of things to have as a companion at all. But generally they're dogs. They can be cats, they can be other animals, but I'm going to speak kind of generically with the dogs. So having a companion dog is easy to come by. You get a dog, you call it your companion dog. You can go online and you can pay $50 to $60 to any number of places on the internet and get a little certificate. They'll send you a little cape for the dog and an ID, and you have a companion dog. And that dog is now certified. You can take the dog into restaurants, you can take him into stores, and you can travel with these dogs. So there really isn't any special training for a companion dog per se. Now, if you're talking about a dog that's for a certain disability, particularly with seizures, they do need to be trained. And this is where it gets a little bit dicey because if you buy a dog and you have it trained, you have to find someone that will train that dog. So typically you go to different organizations who you get the dog and they're trained by that organization, and they can be very expensive. I've been told from $5,000 to $10,000, $15,000. PTS dogs are going for $10,000 to $12,000. The guide dogs are 15 or more because there's such advanced training that's involved. But I think the benefits can be great. Seizure response dogs are trained to stay by someone who's had a seizure, to go fetch medicine or someone, so they're trained not to just guard. We don't want them to guard the person so that nobody can come help them. And so they are specially trained because, you know, many animals, our pets, will do that. They will stand guard. And I think it was mentioned earlier that people are looking for a seizure detection dog, and research shows there's not so much that you can train a dog to do that, although we swear by our, at least pit bull, who takes excellent care of her, although people are afraid of her even though she's a big baby, so they wouldn't get near her, being, you know, Sam there. So there are a lot of different names that they're called, you know, and so it just depends on your individual circumstance. So I think if you're interested, do some research. I think that, Raylan, you have some information online as well. Where's Raylan? About different epilepsy dogs or seizure dogs. You can go online and search. But I think it's worthwhile just so that you have that companionship. And then for kids that are feeling really alone and feeling identified, particularly the teenage years, nice to have a dog that just, you know, they'll love you no matter what. You have a seizure and they're there. They're not going to leave you. And so there's a lot said about that. Any specific questions that you might have?
Do you have any specific resources for seizure detection dogs? You said that they actually can't be trained to do that, but I've heard that dogs or maybe other animals can alert you when you might have one, so you can lay down or, you know, put yourself in a safe place, maybe?
Anyone else on the panel want to address it? I think you talked about it earlier.
Well, I mean, I think that some patients have focal seizures before they have complete involvement of their brain, and so during that little lead-in portion, certainly there can be subtle things. Sometimes it's as much as just pause in the behavior. Sometimes it is things like heart rate changes, and animals certainly can be more sensitive to that. So I don't think that they can necessarily predict a seizure coming, but I certainly think some animals are attuned to picking up the subtle onset of the seizure before it spreads to the whole brain. And so certainly there is the possibility that some dogs can do that. I don't think anyone can guarantee that, but I certainly think that that's why some of the dogs go through special training interacting with the other patients who have frequent epilepsy. And I certainly think that for my patients who do have seizure companion dogs, that it's actually easier to train the dog if the kid has a lot of seizures. If the kid only has seizures once every few months, it's just hard for the animal to get a pattern, whereas the kids who have them every few days, then the animals can pick up on that pretty quickly. But primary onset generalized seizure where it involves the whole brain all at once is not something that the animals can necessarily see coming. But if it is a focal seizure that spreads, then I certainly think that they can pick up the subtle things that a lot of people miss. In the back.
One thing that you need to be aware of, companion dogs versus the ADA definition of a service dog does not include companion dogs. In order to be able to take them into all the different businesses and restaurants and such, that by ADA, that they have to be trained to do something specific to help that person with their specific disability. My wife is the head of or not the head, she has started a program for psychiatric service dogs. And that includes the PTSD dogs as well as others. And so the business owners can't ask what disability that that dog is addressing, but they can ask what it is specifically trained to do. So be careful with the whole companion dog thing, because you can go in with a companion dog and they can deny access. But if it is a service dog, have it trained to do something. My wife's service dog is trained to recognize when she's going into a panic state. Okay. It also reminds her when it's time to take her medications. And fortunately, my wife is all of her medications are BID, so she only takes them twice a day, and they're at specific times. And her dog is trained that if she is not where her medications are, that it gets her attention. It gets her attention to go to those meds. So that my point just being is that I have some concerns about the websites that will sell you those certificates. They will sell you a certificate that isn't worth the paper it's written on in a lot of cases. So just be aware of that, be cognizant of it, go into it with your eyes open. But service dogs, absolutely. You have ADA protection for your service dogs.
Excellent points. Thank you. Sure.
With regard to detecting seizures, and not so much with animals, are there technological devices or things like that that are in study at this point to do that? And if so, how do you become a study participant?
So the responsive nervous stimulator that Dr. Spencer talked about is the only thing that's FDA approved. I certainly think that there are research protocols. I don't think we have any going on right now.
Not right now. Here,
yeah.
Anyway.
I certainly think it depends on the type of epilepsy that you have, and as I said, the seizures where they're primary generalized or affect the whole brain all at once, we're pretty crummy at predicting them, and I think with the focal seizures that we have better abilities to help with that.
Thank you very much.
Let me bring up one of the questions that was asked earlier. So we have a lot of different types of patients with epilepsy, kids, adults, and also men and women. And so, we have different things to consider when we are talking to these patients about their seizures and about how we're going to treat them. And so I wanted to direct a question to Dr. Wong, because I know that she has an interest in this area. What are some of the things you discuss with your female patients who have seizures and having to do with treatment of seizures?
So there are certainly unique things about female patients with epilepsy, and one of the main things pertains to hormonal effects. So over the course of a lifetime, you know, there's menarche and menopause, and just with having a menstrual cycle monthly, hormones can definitely affect seizures. Many people have what we call catamenial epilepsy, where when it's right before or during the time of their period, women can have a flare in epilepsy, and there are certain specific treatments that can help with catamenial epilepsy. There's also issues pertaining to being on oral contraceptives, issues related to pregnancy. So the vast majority of seizure medications do increase the risk of birth defects, but that increased risk can be anywhere from just 2% of a risk all the way up to, you know, 25 or 30%. So it's really important in patients who are considering becoming pregnant to look at all of these factors. But one thing to know is that over 90% of women with epilepsy give birth to normal kids. So that's a very important statistic. And there are certainly things such as like folate supplementation that can lower the risk of birth defects. And then another thing is that women are at increased risk for osteoporosis in general, and a lot of seizure medications, just taking them over decades, can increase that risk even more, and even men with epilepsy. So it's very important to take a good look at this medication regimen and see what are the potential long-term side effects. So, and as far as birth control, it's important to know that drug interactions, so either the birth control can affect your medication levels or vice versa. It can make your birth control not work as well, and certain things can exacerbate seizures, things related to hormone therapy. So a lot of other issues to take into account.
Does anyone have any questions related to that general topic that they'd like to address?
I'm just curious about the hormonal changes. Does the birth control pill seem to help that? And at one point, my daughter did have some testing done, like her blood levels were taken like the week before or on a certain date, I can't remember. Anyway, I never really got the results from that. But is that the only way to find out? Because she does seem to have more seizure activity during the week before and the week of her period than the other 2 weeks out of the month. So I'm just curious, is that the only way to determine whether or not it would be beneficial to add extra medication during that time of the month, or what your thoughts were?
Yeah, so that's a great question. So basically what we know is, generally speaking, estrogen is can potentially increase risk of seizures, and progesterone can reduce risk of seizures. And so just over the course of the menstrual cycle, that can definitely correlate with, you know, peaks in estrogen levels. So right before the period, it's exactly what you described. Seizures can become worse. That can also affect certain medications. So medications that tend to interact with estrogen, it can actually lower medication levels around that time. So it's sort of multiple effects that are going on. There are a number of different solutions we can try for that. So sometimes just increasing medications in general, medication levels, medication doses can help with that. Some people where they're taking certain medications, for example, lamotrigine or Lamictal, if we know that that drop is going to happen, we can anticipate it, and some people do tend to increase levels around that time. There are other sorts of regimen. Sometimes Depo-Provera is actually something that's been shown in very small studies to potentially help with this catamenial epilepsy related to menstrual cycle. And then another thing is that sometimes using sort of a temporary medication for sort of a 10-day course each month to offer extra protection during that time. Those are all possible options, or giving progesterone is another option. Extra.
A question over here.
My name is Mary. I come from Africa, and I have a son who is about 34 years old. It was a twin pregnancy, and when I had him, one passed away at birth. And around the age of 3, he started having what I'll call petit mal seizures, but I didn't know the name. I only came here and knew that name. So they thought it was cerebral malaria. So each time I went to the hospital, I'll not even know how to describe it well because she would just stare at me, sometimes fidgeting. I didn't even know what it was. So they say, oh, it's cerebral malaria. Some would say it's witchcraft. They gave all sorts of names to it. And I was in a city where there was no neurologist. So after a while, I went to a big city where there was a doctor. But my country is French-speaking and English-speaking. So I went to the French-speaking part, which had the neurologist. He didn't explain much to me. He only said, go and keep taking this medication. So I went and continued taking the medication, and he kept having the seizures, the grand mal and petit mal. And each time he had the grand mal, neighbors, like the first time he had it, I wasn't at home. A neighbor, a lady, they said they know how to treat it well. They put him down, restrain him, open his mouth, put a spoon, put some kernel oil. And at one time, he almost passed away because the kernel oil went into his windpipe. And they had, luckily I was in a city where there was a hospital, so they had to send a tube to drain it out. But he kept having the petit mal. So I didn't know what it was. But as luck would have it, I came here in 1997, and he had the grand mal. And they started doing blood giving. They put him on, I think, Depacot or something. It didn't work. They put him on Dilantin. And since then, he has not had the grand mal again because the Dilantin worked. And they've been doing blood draw to see the amount of Dilantin in his blood. But some people have told me that he has been on it for too long, on Dilantin for too long. It's an old drug. There are newer drugs. You should stop it. It makes me confused. Then I think I talked to the doctor. The doctor said, since he has not had any, he's not having any side effects, there's no use trying a new drug since this one is controlling it. So I'm worried on the new drugs and the old drugs. But he is speech impaired, so it doesn't give me much information. Sometimes, especially with the petit mal, sometimes he may just tell me, I had it at night, but he doesn't talk much. But I've not seen any grand mal or any petit mal thing since then. So I don't know whether there's a way you can...
Well, I mean, that's very... I mean, I'm very glad that he's not having those types of seizures anymore. It sounds like that was a very difficult place to get to over many years. I think, you know, you brought up a lot of important questions. One is the question of what we do with patients who are on medications that are working but are potentially older medications, so to speak. And there's not a great answer to that question because it's very individual from one person to the next. You know, we have to basically weigh the risks and benefits of what it means to make a change from one medication to a different medication. And there can be both. Probably what they were referring to are that some of the older medications we know have the potential to result in some chronic long-term side effects. And they may or they may not. Dr. Wong mentioned one of those as being decreased density of the bones over time. So if you're on certain, typically of the older medications for many years, that can be a problem. And so we sometimes, even though people are doing well, we sometimes address those questions because the side effects of many of these medications can be problematic. And they may or may not be for your son, but it is something that we sometimes bring up. And then we have to sit down and discuss with the patients, well, what do we think the risks are for, you know, something getting worse as opposed to the likelihood of something getting better? And that's, you know, that's a very sort of individual discussion, I would say. But I think that the point you brought up is a really important one, and it's a good one to discuss. The answer may be that Dilantin is the best medication, but I think it's still important to think about whether it is or not. Yeah. Does that make sense?
Another question? The question is for the social worker. I don't know the education. She talked about education. Education is a big, it's 50% the treatment. Big help. because education has helped me a lot to handle my son's situation. Like I came here, the first time I went to the office of a neurologist, I saw a small paper which said the first aid treatment for seizures. Don't restrain. It is exactly what my people do back home. Don't put something in the mouth. That is when they open the mouth to put a spoon there, not to make the patient bite the tongue. Don't put anything in the mouth. That's when they put something like kidney oil, which will pass and go into the windpipe. Don't put the patient on the side, and they put the patient facing upwards and press the patient down. So education is a big thing. You talked about, talked about her daughter going to Mexico to create awareness. We need that a lot. Each time I go home, I had a video cassette on epilepsy, how to handle it in schools. I took it to Africa, and when I went there, I went to church groups, I went to other small groups, and just showed family, people, and friends. They loved it. And the nurse in the village called me and said, do you know that after you came and talked to the patients and showed them that video, they started bringing patients to the hospital? They never used to carry them there. They would think it's witchcraft or some other thing. So I will meet you, and you will tell me how she's is there. So I can also
yeah. That's an excellent point. Okay. Let me get to one question that was asked online here, and we'll get back to the question in the audience. I think this is a really interesting question, something we run into quite a bit. So we have a 19-year-old daughter that has been on the low glycemic index for a couple of years, and we definitely see an effect, but we don't have the medical support to know if we're doing it correctly. How effective is diet, such as the low glycemic index therapy, for children and adults? And maybe I'll ask Carter to start this because he has a lot of experience with the ketogenic diet and modified Atkins diet and things of that nature.
So the goals of the medically proven dietary therapies for epilepsy are to try and reduce the carbohydrates that people eat, to try and switch the brain from what it normally gets to energize itself, which is glucose, so simple sugar, to ketone bodies. And ketone bodies are things that your body makes when there isn't enough glucose around, and they're made from breakdown products from fat. So the diet that we know has the most help for controlling seizures is the full ketogenic diet. It's very difficult to do, particularly for people who eat by mouth. I'd say that the majority of my patients who are on ketogenic diet therapy are actually fed formula. Either they take just formula through their mouth or they have G-tubes. But we certainly have a fair number of orally fed patients who are able to do the full ketogenic diet, but it's a lot of work for their families. It involves weighing foods on a gram scale and trying to get things down to 1/10 of a gram. The much more user-friendly version diets that we use are either the modified Atkins diet, which is similar to the Atkins diet you probably have all heard about, where it's higher in fat and protein and lower in carbohydrate, or the low glycemic index diet, where we're trying to encourage families to eat carbohydrates that don't quickly turn into sugars, so that the sugar is, again, not available to the brain as easily, so instead your body will produce the ketone bodies that are the other energy substrate for the brain. And we certainly have the most data in the full ketogenic diet, and over 50% of patients who try a full ketogenic diet will be responders, as Dr. Spencer said, have greater than 50% reduction in seizures. And so we typically try those diets in the patients who are in that sort of 1/3 of the epilepsy pie where they haven't stopped with drugs, and particularly patients who are not surgical candidates. They can't have one part taken out to cure their epilepsy. And so I certainly think that full ketogenic diet is very, very effective, but given how difficult it is, I think that for more of the patients who eat by mouth, that doing either modified Atkins or low glycemic index diet therapy are good options. And so we certainly have 3 dietitians who support me in the clinic in helping work with families to do that. Unfortunately, there is not as much support for dietary therapy in adults. The Hopkins University in Baltimore certainly has the biggest ketogenic program in the world, and they certainly do a fair number of adult patients on either modified Atkins or low glycemic diet therapy. But there are very few dietitians who are working with patients who are adults. So I certainly think that it is an effective treatment, but I certainly think that it is hard to access the resources to be able to do dietary therapy, in part because insurance often doesn't want to pay for it. And so often my patients end up seeing me, and my dietitian's portion of the visit is not covered. And that's just something that we, as a hospital system, have to deal with. But I think that it's much trickier for adult patients where there isn't an organized ketogenic diet clinic, like I said, that I'm aware of other than at Johns Hopkins in Baltimore. But I certainly think that it can be quite helpful, but it does help to have some support, and if you can have a dietitian who's experienced, that's great. There is website information. The Charlie Foundation is a U.S.-based group that focuses on dietary therapy, and then there's a British equivalent called Matthew's Friends, and both of those websites have information that is more heavily towards full keto, but also has modified Atkins and low glycemic dietary advice, and there's a lot of support from families who are using dietary therapy.
So I can speak for the adult end. I don't have any experience with the low glycemic index diet, but the modified Atkins diet is certainly, for select patients, something that I've referred patients for through the adult dietitians. And they're able to help patients kind of figure out whether it's a feasible diet. Basically, what you're doing is limiting carbohydrates very significantly. It's simpler than the ketogenic diet, but it is still a lot of work because you have to look at nutritional facts labels and know everything that's going into your body and how much carbohydrate you're getting in. And it's pretty restrictive. It's you basically have to cut out the large majority of any sugars or starch from your diet. As far as how effective it is, basically the more limiting the diet, the better it works. So on one end, you have the ketogenic diet that has better data, and then on the other end, you have something like the low glycemic index diet where it may not work as well. But it's certainly, I've had at least 2 or 3 patients who have found some success with it, where I have one patient who has generalized epilepsy, primary generalized, not able to get surgery, and so she had her large generalized tonic-clonic seizures controlled, but was still having these myoclonic seizures every so often, and when she went on the modified Atkins diet, she was able to get rid of those small myoclonic seizures and also lost 15 pounds in the process and was very happy with that.
Brent, I think we had a question down here in the corner.
No, I wanted to comment on what the lady said about long-term medication. I have been on Dilantin for almost 50 years now, and I've had several other medications added to it, and I'm suffering some of the side effects of it, but they are what helped me not have seizures. I have about 2 or 3 a month, including grand mal and petit mal and auras, but I'm alive, and I'm happy to take the Dilantin, so I just wanted you to know. Tell your son, keep up his Dilantin.
I think we have time for maybe one more, or potentially 2 if it's short, and then we'll let you guys get some lunch for the afternoon.
Well, we have 2 arms up here, so maybe we can get 2 questions.
Thank you. My daughter is 12 years old and has been diagnosed within the last 6 months, so I'm still in the learning process, a bit overwhelmed. But I had a question and was wondering if you could touch base on something that Dr. Spencer was discussing earlier with the Fycompa, the medication. He had a graph that showed excitation and inhibition, and I'm wondering, I guess my question for you is, my daughter recently has no inhibition, and so there's no fear of any kind, no consequences mean anything to her. I'm getting emails or phone calls from her school every day from all of her 6 teachers and the principal, and I'm wondering, could this be because of the medication she's on? This isn't something she's had through her whole life. It's just been recently.
Yeah, I think those are really good questions. I'm going to ask Carter to comment on them in a second here. The answer to the question about could it be medications is it could be medications. And that's definitely, many of our medications are very effective, but we have to balance them with side effects that are potentially very problematic. Some patients do very well and don't have those side effects, but other patients don't respond well or have side effects that are potentially problematic, including perhaps mood side effects. So I don't know, but it's possible, certainly. And so I think that's worth considering. We have to make sure that the treatment that we provide is not worse than the problem that we're trying to solve. That's something that we really wrestle with, and our medications are very messy, frankly. They cause a lot of problems. With respect to the inhibition excitation, what Dr. Spencer was getting at was a little bit on a more cellular level, just sort of the very basic mechanisms of why the electrical discharges and seizures start. So there are lots of sort of chemical messengers that make individual cells and groups of cells more excited electrically or less excited electrically. The drugs work at that level to try to balance that out, hopefully, and an imbalance can cause those problems. The kind of inhibition I think that you're talking about may be related to that, but is also potentially a bigger issue. Maybe I'll ask Carter to comment on that.
Absolutely, because I really think of my children that I take care of as having brain problems, and inhibition is really something that we need to learn how to do, and it actually takes a lot of brain working together to know when to not act out, and I certainly think a lot of children do act out normally, and then a lot of kids with epilepsy act out more. And I certainly agree with Dr. Motika's statement that some of our drugs we know make them worse. I mean, certainly I tell my families 10% of my kids on levetiracetam or Keppra are going to have behavior problems because of the medicine. And so if that's the medicine, then that's certainly something. And I think that we have some concerns about Fycompa possibly being another medicine like that. But I certainly also know that any of our seizure medicines can have any side effect in any child. And so even though there are drugs that I often choose in a child who might be having impulse control problems like that, that might help stabilize it ideally, it doesn't always work. But there certainly are other medicines that when I hear a family bring to me a child who has epilepsy and has some impulse control problems, I will often stay away from certain drugs and choose other drugs preferentially to try and help ameliorate that side effect. But I certainly think that the brain dysfunction that causes the child to have seizures also often causes them to have behavior problems. And usually we try and tailor so that the drugs we're choosing help minimize those problems. But often we're not able to make them completely go away. And so I certainly think that behavioral intervention and those types of things have to be a part of the management of a child with epilepsy who's having those kinds of problems because they're incredibly, incredibly common.
So if you have a child who has the VNS and now you have the new RNS device, if they were, if they had good criteria to get an RNS device, would the VNS device complicate that or make them ineligible?
That's a good question. I'll have to ask Dr. Spencer. I don't know the inclusion and exclusion criteria. Do you, Carter?
Well, I mean, I guess if it's a child, the RNS isn't yet to be approved for children,
right,
so that's just a non-option. And I certainly think that the RNS is, to some extent, really trying to target a population of patients who clearly have something that's wrong with just one part of their brain, and they have focal seizures that come from that part. And I think that more often I prescribe VNS in patients who have generalized epilepsy or multifocal epilepsy, where the responsive neurostimulator wouldn't be an option, either because it involves the whole brain or involves 3 or 4 different parts of the brain, and so we couldn't put RNS electrodes over all those different places. So I think they probably help different patients in different ways.
My suspicion is that having had a VNS may not be exclusionary to have an RNS, but there's probably some sort of, the VNS may have to be off or removed or something. I'm not certain, but I can ask Dr. Spencer about that. Do you know?
So my question was just some advice. My 19-year-old who has grand mal seizure, she suffers from really extreme headaches constantly. She's on Keppra and Lamictal to control her seizures, and her neurologist had her on Topamax, to try to combat the headaches. However, that's not working. And I understand, people with epilepsy, this is a very common problem. I just feel like her neurologist isn't taking it seriously enough, and she's a very motivated person and often can power through it, but there are just days that she's just miserable. So I'm just wondering, what would you recommend in that situation?
Anyone want to chime in?
So first of all, I think it's important to maybe figure out a diagnosis as far as the headaches go. So looking for are there features of migraine headaches? Is this something separate from the epilepsy, or if these are very clearly linked to seizures? So if it's that every time she has a seizure, she has a headache, then different therapies could be considered. If Topamax wasn't an option, zonisamide or Zonegran is also something similar in the same class as Topamax, perhaps with not as many side effects that could also potentially combat headaches. Sometimes patients who clearly have a seizure and then a subsequent headache, we just treat it as needed with just painkillers, either over the counter or prescription painkillers. But again, we don't want to do that too often. If it's daily, that's different from if it's happening like 1 or 2 times a month.
Yeah, I think those are good points. Victoria brings up the idea that headaches, first of all, are a very common neurologic issue, but we also know that they're often associated with epilepsy as well, and that there's a higher number of people with epilepsy who have migraines or headache-related type problems. It's important to try to figure out if it's that's going on, or is there another cause for the headache? Is it the medications? Is it a sleep problem? Is it related to anxiety, stress, etc.? Sometimes trying to identify, what may not have been identified as a trigger is really important, and that can take a little work, but that may actually be the more effective thing in the long term too. Sure. Sure.
Before you do that, I just wanted to let people know that if your question did not get answered here today, or you're online viewing and you have a question that came up, please feel free to email us at mail, M-A-I-L, at epilepsynw.org, and we'll do our best to get you an answer to your question if you didn't get a chance to ask it today here or also online.
I'd like to thank our panel for taking part, and also everyone who submitted questions and who asked questions here today. I hope it was helpful for everyone, and a lot of us will be around here afterwards and can answer some questions as well. But we want to give you time to get lunch before the afternoon session.